What would your diagnosis be if you asked a patient to draw a clock and they did this? Neglect. And by the end of the video, you will learn about both neglect and visual field defects, how to trace the visual pathways and tell me exactly where the lesion is at the bedside. I'm a neurologist. I teach this to medical students and residents every single day, and this series builds a complete map of the nervous system. Each pass we go deeper and deeper than the last time. You don't need to have seen anything else to follow this. Everything you need is right here. My goal is simple: teach you neuroanatomy you can actually use at the bedside itself. So let's start with the visual pathways and draw them out. So we're going to start with both eyes. This is going to be our left eye, and this is going to be our right eye. And please, excuse my horrendous drawings. At the front of the eyes, we're going to have our lens. And light's going to come in through the lens and hit the back of the eye, which is the retina. And that retina is going to have nerve fibers that send that back to the brain. This is our nose right here. So our nose is in the middle, and our eyes are looking out into the world. So we would call this side our nasal aspect, and we would call this side our temporal aspect. So when light comes in through the eye, light coming from the left side of the world hits the retina on the right side. And that is really hitting the nasal fibers on that side. I'm going to make these fibers nasal, and we're going to make these fibers green, which is temporal. And same here, we've got temporal fibers and we've got nasal fibers here. So when we are getting light coming in, it actually crosses over at the lens and hits the opposite side. So similarly, we've got something that's on the left side of our vision. It's coming through the lens, and on the right eye, it's still hitting the right side of the eye, but it's hitting the temporal fibers. So left side of the world is hitting the right side of each eye. In the left eye, it's going to be the nasal fibers, and in the right eye, it's going to be the temporal fibers. So from here, what's going to happen is these fibers from the retina are going to make their way and form the optic nerve itself. And they're going to stay on their corresponding side. So we're going to have the temporal fibers on the temporal side. We're going to have the nasal fibers on the nasal side. So it's going to stay like that. What's going to happen is these are going to come back to a region called the optic chiasm. So we're going to label this optic chiasm. So this is your optic nerve. This is your optic chiasm. And it's here that things start to cross over and split around. So the temporal fibers will stay on the same side, but the nasal fibers will actually cross. So here we have the nasal fibers crossing around, and on this side we have the nasal fibers crossing over. And here the temporal stays on this side. So what's happened in this instance? Well, when we have light coming in from the left side of the world and it's hitting the right side of our eyes, well, after the chiasm, those fibers have actually joined together. So this nasal fiber that's catching the left side of the world has crossed over, and these temporal fibers, which are catching the left side of the world, have crossed over. So after the chiasm, what we end up getting is a convergence of the actual signals. The optic nerve from each eye carries visual information towards the chiasm. But now here's where it gets interesting. Think about how light enters the eye. The lens inverts the image, so light coming from the left visual field hits the right side of the retina. The nasal retina on the right eye and the temporal retina on the left eye. At the chiasm, the nasal fibers from each eye cross over to the opposite side, whereas the temporal fibers stay on the same side and they do not cross. So after the chiasm, this is called the optic tracts. So optic nerve, optic chiasm, and then after that, optic tract. tracts. So after the chiasm, the left optic tract carries fibers from the right visual field of both eyes. The right optic tract carries fibers from the left visual fields of both eyes. So the right optic tract, if we were to draw what the patient was seeing in terms of their visual fields, the right optic tracts would be seeing the left side of the world. And that's because the image from the left side of the world has made its way onto the right side of the eye. The fibers have crossed over, and the right optic tract is now carrying those fibers combined. Now, this is not an accident of anatomy. The nervous system is organized around one fundamental principle. Each hemisphere deals with the opposite side of the world. Now, you already know this. Motor cortex on the left drives and controls the right hand. Sensory cortex on the left processes sensation from the right side of the body. The visual system follows the exact same rule. The fibers cross at the chiasm so that the left hemisphere receives the right visual field and the right hemisphere receives the left visual fields. And as we will see in a moment, attention follows exactly the same principle. So one thing I'm not going to cover today are lesions before the optic chiasm. Anything affecting one of the optic nerves alone causes one eye to lose vision, monocular vision loss, but we'll do that another time. Today we're going to keep it simple and we're going to focus on post-chiasmal lesions. Now let's continue down our pathways. So the left tracts end up at the thalamus. So these tracts go to a region in the thalamus called the lateral geniculate nucleus. You don't need to know that now, but know that it goes to the thalamus. You already know the thalamus from a map. It's a great relay station. The visual pathway is no different. Everything passes through the thalamus on its way to the cortex. So these are called your optic radiations. And there is an inferior radiation and there is a superior radiation. So from the lateral geniculate nucleus, or from the thalamus, the fibers fan out into the optic radiations. And here they split into two distinct pathways. The inferior fibers carrying information from the upper visual field sweep forward and down through the temporal lobe in something called Meyer's loop. So these go through the temporal lobe, something called Meyer's loop. Whereas the superior radiations go through the parietal lobe. And so they converge here in the primary visual cortex in the occipital lobe. Both pathways arrive at the primary visual cortex in the occipital lobe, and this is where vision actually happens. Your eyes collect the light, the brain creates the image. And I want to draw this just on our initial schema here, and let's use yellow. And so your eyes might be here, taking this information back to your brain. And as they get to the thalamus, which is kind of in the central region here, we then have fibers making its way forward and then back to the occipital lobe. And they're going to be our inferior radiations. And we've got fibers coming through our parietal lobe back to the occipital lobe, and both back to this primary visual cortex. So let's label that as our superior radiation. So inferior fibers going through inferior radiation, optic radiation going through the temporal lobe, superior optic radiations going through the parietal lobe, the lobe that's superior and higher up. Now let's talk about what happens when you damage different parts of this pathway. First, damage to the optic tract itself, and we spoke about this. You damage the optic tracts and you damage all the fibers representing one entire visual field. You lose the entire visual field in both eyes. A right optic tract lesion gives you a left homonymous hemianopia. The left visual field is gone in both eyes. Homonymous because the same side is lost in both eyes simultaneously. So that's what we get here for a right optic tract lesion. Now, the optic radiations are different because the radiations have already split into two separate pathways. you can damage just one part and get a partial defect. And we would call that a quadrantanopia rather than a full hemianopia, because only a small quadrant will be involved. So if we were to damage Meyer's loop in the temporal lobe and you knock out the inferior fibers, the one carrying the upper visual field, the result is an upper quadrantanopia. So you would just get the upper quadrant being involved. This is sometimes called pie in the sky because that is exactly what is lost. The upper quarter of the visual field, same side, both eyes. Now, if you damage the parietal radiation instead, you lose the superior fibers and hence the lower visual fields. So you get a lower homonymous quadrantanopia. So to summarize, tract lesion gives you a full hemianopia. Radiation lesions give you quadrantanopia. Now here is an easy way to remember which radiation gives you which defect. Think about it in both axes. So left and right, but also top and bottom. The left brain controls right vision. You already know that. But apply the same logic vertically. Inferior fibers in Meyer's loop travel through the temporal lobe and they carry the upper visual fields. The superior fibers travel through the parietal lobe and they carry the lower visual fields. Bottom carries top, top carries bottom. So if you see a left lower quadrantanopia, work backwards. Lower visual fields means superior fibers, which goes through the superior lobe, which is the parietal radiations. Left side means right hemisphere. The lesion is the right parietal lobe. Once you see that logic, it becomes automatic after that. Now, what about the occipital cortex itself? If we get a stroke here, we get a homonymous hemianopia. And that's because all the fibers have now come back together again. But there's one important feature. The macula is spared. Now, the macula is the central part of the retina and it's responsible for sharp central vision. Central vision goes to the occipital pole, which is right at the tip and the middle of the visual cortex. In PCA strokes, posterior cerebral artery, we'll get to vascular anatomy soon, that affect the occipital lobe, central vision is often preserved, even when the peripheral field is gone. The reason is dual blood supply. Both the posterior cerebral artery and the middle cerebral artery supply the occipital pole. And this is because it's so critical, so important, we don't want to lose all your central vision when you have a stroke. So this collateral supply. So when a PCA stroke takes out the occipital cortex, the MCA contributes to the occipital pole and can preserve the macular representation. Now we'll go into vascular anatomy properly, but just for now, know that macular sparing points towards an occipital cortex lesion due to a stroke rather than a more anterior radiation lesion. One thing to note is that if you knock out both superior and inferior radiations, then you will also get a homonymous hemianopia, and that's because you've knocked everything out, both quadrants, and so two quarters make a half. And you see that with very large strokes knocking out both the parietal and the temporal lobes as well. And now on to neglect. Neglect is not a visual field defect. The visual pathway is completely intact. This is something different and more profound. Now remember what I said at the chiasm. Each hemisphere deals with the opposite side of the world. This applies to attention as well, but here is the asymmetry that makes neglect so fascinating. So the left hemisphere directs attention to the right side of the world. The right hemisphere directs attention to the left and the right side of the world. It does both. It's a backup system. So when the left hemisphere is damaged, you'd expect that the right side of the world would get neglected, but the right hemisphere steps up and covers right-sided attention. It says, hey, I've got you covered. But when the right hemisphere is damaged, specifically the non-dominant right parietal lobe, there is nothing to fall back on. The left side of the world simply disappears from the patient's awareness. Neglect is much less common and much milder with left-sided lesions for exactly this reason. This is why neglect is almost always from a right, non-dominant parietal lesion, and it is almost always the left side of the world that disappears. Now this comes in two forms. The milder form is inattention or extinction. The patient perceives things on the left side normally when you test each side alone. But when you stimulate both sides simultaneously, they only register the right. The left side is extinguished by competition from the right. The more severe form is full neglect. The patient ignores the left side even with unilateral stimulation. They may not dress their left arm. They eat only from the right side of the plate. And when you ask them to draw a clock, they draw only the right half of the clock face. They're not blind. They're inattentive at a level deeper than conscious awareness. Now, how do we test this at the bedside? For visual fields, it's quite easy. Confrontation testing. You cover one eye of the patient, so you cover their eye, you hold up your fingers, and you bring it in and you say, can you tell me when you see my fingers moving? Not a very sensitive test, but at the bedside you can do that. And for each eye, you check each of the 4 quadrants. You're looking for a consistent field defect that respects the vertical midline. That is your post-chiasmal signature. For neglect and extinction, we do 2 tests. The first, double simultaneous stimulation. Stand in front of the patient, wiggle your left, then your right, and then both simultaneously. If they miss the left side only when you stimulate both sides at once, that is extinction. You can do this for touch as well. The second, clock drawing. Ask the patient to draw a clock face. Put all the numbers in and set the hands to 10 past 10. A patient with neglect will crowd all 12 numbers onto the right half of the clock, and the left side will be empty or missing. Okay, now, let's do a quick case. A 58-year-old is referred with a visual complaint. They have noticed something is off with their vision for the last few weeks. They cannot see the top right of their computer or TV screen. Now, on examination, you find a right upper homonymous quadrantanopia. So an upper right quadrant of the visual field is gone in both eyes. Now, no other neurological deficits are present. Where is the lesion? So let's go back to the pathways and apply that logic. We've got upper visual field. That means inferior fibers. That means Meyer's loop, which means temporal lobe. The vision loss is on the right, so the lesion has to be on the left side. So we're looking at a left temporal lobe lesion. That's how simple it is, and that is what lesion localization feels like when it clicks. Next week, we move down the longitude axes and out of the cortex entirely. We have spent several episodes at the top of the map, and now we're going to go slightly down into the subcortical regions, specifically the internal capsule and all the fibers that make their way through it, specifically the corticospinal tracts. A small lesion, an enormous deficit, and a very satisfying localization. That is next week. If you found this useful, subscribe, set a reminder so that you can get the next episode next week. And if you know someone learning neurology or neuroanatomy, please send it their way, because learning together is so much more fun. See you next week.